Liver function test, second basic concept for hepatology or viral hepatitis, whichever we read. Liver function test, we all know, set of investigation: bilirubin, SGOT-PT, alkaline phosphatase, GGT, albumin, and prothrombin time. We think that sometimes that entire LFT is one investigation, but actually every component of LFT is giving you some different information. Out of which first I will talk about the bilirubin, then other component. And so before we move to the bilirubin, we should know the pathophysiology, how bilirubin is produced. It is produced by the destruction of RBC, and from there what bilirubin is produced, it is an unconjugated bilirubin. Then it is taken up by the liver and it will be conjugated. Conjugated bilirubin is excreted by liver into the system, and where it is excreted is an important point which you should know. You can see I have intentionally kept this line is thick and this line is thin. In normal condition, most of the conjugated bilirubin is excreted in the biliary system, from where it goes down into the GI tract. That is the normal pathway, and then it goes for the recirculation, enterohepatic circulation from small intestine. But if there is any problem, any obstruction here, then this line is thinned up and this line is thickened up, and then the conjugated bilirubin goes into the systemic circulation. And that's why whenever we see report, then what is the conjugated fraction, what is the unconjugated fraction, that helps us that where the problem is. So based on this bilirubin metabolism in one slide, you can see there are three types of disorder which can cause jaundice. First can be the increased destruction of RBC, where we know it is hemolytic jaundice. Second could be the abnormal function of liver, means liver failed to take up the unconjugated bilirubin or failed to excrete the conjugated bilirubin, and that is called hepatocellular jaundice. Third, the problem could be in the biliary tract because of obstruction, which is called obstructive jaundice. So this is the entire basis of three types of jaundice, which is hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice. Now coming to the other component of liver function test. So before we move ahead, we should know this is the hepatocyte, this is the sinusoid. Plates of hepatocytes are lying like this, parallel to each other, and the two hepatocytes are joined with each other at this site, which is called bile canaliculus. So here these bile canaliculus keep on joining and getting bigger and bigger and form the bile duct, which we had seen in the last slide. So from here, liver is taking nutrition, etc., which is coming from the blood and excreting through the biliary tract. Now this is an important slide which will help you to understand entire component of liver function test. This component is cytoplasm, it is mitochondria, and this is bile canaliculi. ALT means SGPT, it is located in cytoplasm. That is why I have written it there. Mitochondria, we can see there are two enzymes written, LDH and AST. So these two enzymes inside the hepatocyte are primarily located inside the mitochondria. The site of position of enzyme will determine basically where the injury is, and that will help you to understand the level of elevation. And alkaline phosphatase and gamma GT are located here in bile canaliculus membrane. So now you will know that every component is telling you a different type of information from a liver cell. So if there is injury to the liver cell, obviously the first injury will happen to cytoplasm, and cytoplasm will be released, and ALT, AST will be released. But AST is located deep into the mitochondria. So if the injury is superficial, minor, AST will not be elevated, but ALT will elevate very fast, and that is why ALT is more sensitive, more specific for liver injury than AST. If there is injury to the biliary tract, obviously pressure will build up in the biliary caniculi and the enzyme will be released, and so we will have alkaline phosphatase and gamma GT elevation. If there is long-term injury, then AST will be more elevated than ALT, and that is why in most of the cirrhosis patients we find that AST is elevated more. ALT-AST ratio is reversed, what is typically known as, because whenever there is long-term injury, AST will be elevated more. One of the reason is AST after production, it is cleared by the endothelial cells which are lining the sinusoid of the liver. And whenever there is cirrhosis or fibrosis, the sinusoid cell blood circulation is not normal. Those are bypassed. So AST is not cleared from the sinusoid, and that's why AST goes up. And if there is alcohol specifically damage to the mitochondria, then we have AST elevation. Why? What alcohol does? It causes uncoupling of oxidative metabolism inside the mitochondria. So mitochondrial toxicity, and that's why in alcoholic cirrhosis, alcoholic liver injury, AST is more elevated than ALT. Right? So with every component of LFT is giving you different set of information, and you can interpret it accordingly. Then another function is synthetic function of liver. Two important components, which are the components of liver function test, is albumin, and second part is clotting factor, prothrombin time. So these two functions are giving you information how much is good is the synthetic function of liver. It is not giving you information how much is injury to the liver. Synthetic function specifically, albumin and prothrombin time. So if we summarize, total bilirubin and conjugated bilirubin fraction, they are telling about the conjugation capacity of liver and the excretory capacity of liver. ALT, AST, they are telling about the injury, how much injury to the liver is. Because if superficial injury, ALT will be more elevated. If prolonged injury or consistent injury, deeper injury, then AST will also be elevated. Alkaline phosphatase and GGT, they are telling about the biliary tract injury. And albumin and prothrombin time, they are giving you information about the synthetic function of liver. So every component of liver function test is giving you a different set of information. And that's why probably when we are monitoring or following our patient, we need not to test every component of LFT, just we need to monitor a specific component of LFT. So whenever we have LFT derangement in our patient, we have to how to approach this patient. Now, after going this much of basic information, we will approach a patient with LFT derangement. First, we have to see whether bilirubin is primarily elevated or not, or enzyme is elevated. If enzyme is elevated, there can be two possibilities: whether ALT/AST is primarily elevated or alkaline phosphatase is more elevated. So we can have three types of condition: 1, 2, and 3. Each will be taken separately. First, we are seeing that bilirubin is elevated. Then in bilirubin component, we have to see whether conjugated bilirubin is elevated or unconjugated bilirubin is elevated. If conjugated, then it can be disease of liver, means hepatocellular jaundice, or it can be disease of biliary tract, but it cannot be a disease of hemolytic system, right? So we can do an ultrasound. Ultrasound will help you to exclude biliary obstruction. If biliary obstruction is excluded, you are left only with hepatocellular jaundice. So with this much basic information, you can conclude based on LFT pattern and based on ultrasound that the patient is having hepatocellular jaundice. Cause could be anything. If no biliary obstruction, then there could be different possibilities, which I will not go into the detail. Then if we have enzyme elevation and ALT/AST is elevated, it is not the ratio, it is ALT or AST. Most of the time you focus on ALT elevation, basically. You can read it as it is. There can be extrinsic causes which are reversible, like alcohol, obesity, hepatotoxic drug. The most common hepatotoxic drug are anti-epileptic drug, anti-tubercular drug, and estrogen. These are the three most common group of drugs, sometime in aside also. There could be viral hepatitis, which we are going to deal in depth, and that's why it is making a background. Then there can be intrinsic causes like autoimmune hepatitis, genetic disorder, which are more in domain of hepatology than journal physicians or at MD level teaching. Then we can have alkaline phosphatase elevation. We can see the ratio of ALT elevation versus alkaline phosphatase ratio, and using this approach, we can reach to some conclusion that my patient is having cholestatic jaundice or hepatocellular jaundice or mixed pattern, because each cause is giving a specific type of jaundice pattern, and that will help. I will not go in detail on these things because then it will become more of hardcore hepatology than general viral hepatitis. So if you have alkaline phosphatase elevation, first thing we have to see GGT elevation. If GGT is normal, that means this alkaline phosphatase, the source is bone, not the liver. So if GGT is normal, it is a non-hepatic cause. We have to look for some other source of GGT, alkaline phosphatase elevation. If GGT is elevated, then we have to do ultrasound again to exclude biliary obstruction. If biliary obstruction is not present, that means it is non-obstructive cause for cholestasis. The causes could be many more. So it is a general overview, general approach, how you can understand. So most important investigation is the what fraction of bilirubin is conjugated. Second, what is the ultrasound finding? Third, whether alkaline phosphatase is elevated or not. If alkaline phosphatase is elevated, whether GGT is normal or not. These four investigation will take you to some reasonable conclusion that which type of disease you are dealing with. Just to differentiate that ALT, AST, most of the time we take it as a single investigation. There are two different investigations. They have marked difference between the two different enzymes. ALT is located primarily liver and very small amount in kidney, right? And probably that is one of the reasons in chronic kidney disease patient, ALT level is markedly normal or low because the kidney source of ALT has gone. There are two sources. But in AST, we have other sources. The biggest source is RBC and muscle. Liver is not a big source of AST in the serum. Because of different location and widespread location, AST is less specific investigation than ALT. ALT is located in cytoplasm, AST is located in mitochondria. As I have explained earlier, that means to release AST from liver, you need a higher degree of injury. But to release ALT, you just need minor degree of injury, any form, because it is superficially located inside the cytoplasm. And ALT have a half-life of 48 hours. AST has 18 hours. So what does it mean half-life? Half-life means once ALT has gone up, it will come down much more slowly, but AST will come down very fast. So if you follow your viral hepatitis patient, AST goes up, but it will come down very fast in a week or two, but ALT will continue at high. So sometimes we may get confused that why there is a discrepancy between the two enzymes. This is the reason for discrepancy, that why one enzyme is not coming down. Whenever we are dealing with ALT, AST, which we must understand that its level is affected by some factor like age, gender, nutrition status, food intake, exercise, and delay in sample processing. Why by age? Because age is affecting the muscle mass, and muscle is a source for AST. Age will affect blood volume. RBC is a source for AST. Age will affect the liver volume to some extent, very little, not much, and liver is a source for ALT. So age is an important factor. Gender, again the muscle mass is different between the male and female, so the AST level will be affected. Nutritional status, again the muscle mass and RBC count will affect, so this will be affect. Food intake, obviously when you will take food, liver will be exposed to lots of toxins and products coming from the gut, so the machinery of liver will start working, some degree of injury will happen, and ALT level will go up. That is why LFT is always advised to test in fasting condition. Exercise, because of muscle is the source, muscle injury will happen when you do exercise and AST will be released. And delay in sample processing, because whenever there is a delay, AST will be released from the RBCs and they will falsely elevate the serum AST level. And if you cannot correct for the age and gender as of now, but and nutrition, but you can take care of food, exercise, and delays, three major factors. And that is why typically is advised that LFT should be tested after overnight fasting in the morning condition, in the morning time, because at that time exercise will not affect, fasting will be taken care of, and always whichever sample is reaching lab in early morning hour are definitely processed on the same day. If sample is reaching 2 o'clock in the lab, there is a chance that the sample will be left in the lab for next day processing. So delay in processing will be taken care of, and that is why typically it is taught that LFT should always be given in the morning hour instead of giving in the evening or night. So reference range is important concept, because classically we consider that 40 international unit, and still we are also practicing 40, but now it is changing everywhere. You may find that 18, 28, 26 different level. I will not go in all those details. You can take still 40 is important. What I want to give message in this slide is, whenever there is a elevation of ALT or AST, don't take it the absolute value. You take it how many fold it is elevated from the baseline. If you take 40 as the baseline, then 120 should not be taken as 80 unit elevation. It should be taken as 3-fold elevation. So whatever number is, divide it by 40, and then that is more important in present era of management of liver disease than absolute elevation of ALT-AST. And this is another important message, that ALT-AST level does not correlate with the severity of liver injury. It is an indicator, but it does not correlate very well with the degree of liver injury. And yes, important. It has nothing to do with serum bilirubin level. In typically viral hepatitis patient, you will see that bilirubin continues to go up, but OTPT comes down. These two things have nothing to do, because of very different. Bilirubin is giving a different function. SGOTPT is giving a different thing. That is why they are not correlating with each other. Ratio, ALT-AST ratio, we were being taught during our MBBS day, but in present era, it is not of much use other than few of these conditions. Alcoholic liver disease, as I discussed, because of mitochondrial toxicity. Wilson disease, why in Wilson disease? Anyone? Why in Wilson disease AST is elevated than ALT? Because of hemolysis. Because of hemolysis, right? Liver cirrhosis, again I have explained why AST is elevated, because it is not cleared from the sinusoidal cell. Non-hepatic cause, hemolysis, muscle disease, and heart disease with sources for AST. So these are the conditions where AST can be elevated than ALT. Albumin is not a marker of acute injury. It is a marker of chronic injury. Chronic injury, always. If albumin is low, there can be 2 or 3 most common cause. One could be the chronic liver disease. Second could be the nutritional status. And third could be the albumin loss. Loss could be through urine or through stool. So these are the 3 common causes for low serum albumin. Prothrombin time. This is very interesting investigation, which we always barge upon in our day-to-day practice every day. This is the one liver function test which is derange last. Whenever there is liver injury, this is the investigation which will derange at the last. It will remain intact. This is the last, you can say, army man. So this will be destroyed at the last, and it will recover first. So if we have to monitor a patient, that is why when you read, when we will talk about ALF, we will focus that please monitor only and only INR, 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 no other investigation. This is the investigation which will go last, bad, and recover first. These tests are of very limited value. Just I have included because we keep on reading these things in our textbook, but we never do these tests, and they have very limited value. LDH have value only in one condition in hepatology, and that is ischemic hepatitis, where LDH is very high. So in summary, liver function test is not a single test. It contains lots of components. Every component is telling about a different information, and one information has very limited thing to do with the other one. So we have to read and we have to decide what we need to see in this patient. Albumin is an indicator of chronic injury. ALT, AST, they are more marker of acute injury. AST is more in favor of chronic injury. Prothrombin time is the last investigation to derange and recover fast in patient with liver injury. So if there is any question, we can answer. Otherwise, we can move to the